semester presentation is on peritoneal metastatic disease. The first question I will answer is, what is the peritoneum? The peritoneum is the largest and most complex arranged serous membrane in the body. The potential peritoneal space and peritoneal reflections form the peritoneal ligaments, mesenteries, omentum, and the natural flow of peritoneal fluid determine the route of spread of intraperitoneal fluid. Consequently, that fluid also determines the spread of disease within the abdominal cavity. There are 4 ways that metastatic disease of the peritoneal cavity spreads. You have direct spread along the peritoneal ligaments, mesenteries, and omentum to non-contiguous organs. There's also intraperitoneal seeding via acidic fluid, lymphatic extension, and then also embolic hematogenous spread. Some of the most common primary sites are ovaries, stomach, and colon, and more least common sites are the pancreas, biliary tract, kidney, testicles, and uterus. Metastatic disease is the most common malignant process involving the peritoneum. Metastasis may also arise from tumors such as sarcomas, melanomas, teratomas, and embryonic tumors. Peritoneal metastases develop from cellular implantation across the peritoneal cavity. Earlier, I had said the 4 ways to spread peritoneal metastatic disease. I'll start with talking about the first one, which is direct spread. Direct spread is a direct invasion from primary tumors to non-contiguous organs that occur along the peritoneal reflections. These peritoneal reflections include 8 ligaments, which are the right and left coronary, falciform, hepatoduodenal, duodenal collet, gastrosplenic, splenorenal, and phrenococolic ligaments. There's also 4 mesenteries, which is the small bowel mesentery, the transverse mesocolon, the sigmoid mesocolon, and the mesoappendix. There's also the 2 omentas, which is the lesser and greater omentum. Spread along these potential reflections is commonly seen with malignant neoplasms within the stomach, colon, pancreas, or the ovary. Secondly, there's intraperitoneal seeding. Intraperitoneal fluid is constantly moving and circulating throughout the abdomen. It allows transcolemic dissemination of malignant cells. For females, the most common tumors to spread this way are ovarian tumors, and then for males, the most common way it spreads is through the GI tract, such as cancer of the stomach, colon, or pancreas. Some of the most common sites for intraperitoneal seeding is the pelvis, especially the pouch of Douglas, the right lower quadrant at the inferior junction of the small bowel mesentery, the superior aspect of the sigmoid mesocolon, the right pericolic gutter, and then spread of the right subhepatic and subphrenic spaces is also frequently seen. Almost 90% of patients with ovarian cancer have peritoneal implants at postmortem, and 60 to 70% of these have ascites. The third way of spreading is lymphatic metastases. Lymphatic metastases is very rare and plays a minor role in the intraperitoneal spread of metastatic carcinoma, but it's very important to the spread of lymphoma to mesenteric lymph nodes. Almost 50% of patients with non-Hodgkin's lymphoma will have mesenteric nodes at presentation, with only about 5% of those patients with Hodgkin's disease. The last form of spread is the embolic metastases, which is the abdomen is a common site of hematogenous metastases from both intra-abdominal and extra-abdominal primary tumors. The tumor emboli spread via the mesenteric arteries to deposit on the anti-mesenteric border of the bowel and in the small arterial branches where they grow into mural nodules. The most common tumors that metastasize embolically to bowel and the peritoneal reflections are melanoma, breast, and lung cancer. And usually this occurs many years after their primary cancer has shown. So how does ultrasound play a part in peritoneal metastatic disease? With ultrasound, it's not really the best way to per se diagnose. It's not the gold standard to diagnose peritoneal metastatic disease. That's more like CT and MRI. But with ultrasound, we can demonstrate superficial peritoneal and elemental metastases as small as 2 to 3 millimeters in the presence of ascites. And those ascites usually are like anechoic or have low level echoes. Although the centrally located deposits will not be visualized because of acoustic impedance of bowel gas and liquid. And then ultrasound is used for image-guided aspiration/drainage of those ascites and the biopsy of superficial peritoneal deposits. Actually, last week in my clinicals, I actually met a lady who comes and does therapeutic paracentesis. She had ovarian cancer, and unfortunately, it is fatal for her. But they do the draining to just kind of relieve it for her, relieve the pressure and the buildup of all the fluid. Some of the sonographic findings for peritoneal metastatic disease, the metastasis form a nodular sheet-like irregular configuration. There's multiple small nodules, which they have intermediate echogenicity, and they are hypoechoic compared to the peritoneum. They're seen along the peritoneal line though, and the larger masses obliterate the line and cause adhesion to bowel loops. Treatment and prognosis. The sad thing is with peritoneal metastatic disease, it's usually not locally treated because the prognosis is usually very poor. But there is palliative care, such as the repeated ascites drainage and bypass enterostomies to prevent bowel obstruction is more than likely the route taken for patients suffering. It focuses on providing the patients with relief from the symptoms, pain, physical stress, and mental stress. And that is my presentation. Please do not judge me. I can't pronounce all these big words very well, but I did try very hard. Thanks.